right. Any other questions?
Yeah, I actually had two questions. So, like, as you're going through third year and trying to figure out where to apply for a ways, like, I feel like I'm changing my mind on what I want to do almost every month. So I feel like if I lock in on applying to one specialty, like, is it easy to change a ways when you get to fourth year? Yeah, kind of like what do you suggest for that?
So give me just for everybody listening here, give a brief synopsis of like your top two or three preferred specialties right now.
So I pretty much alternate between EM and Gen Surge, but I am pretty much changing my mind every month.
Okay.
'Cause I'm like learning new things. So right now I'm planning to apply for a ways in EM, but then like I don't want to be in the position where I want to switch again late and then am like either scrambling for spots or something like that. So yeah, just curious what your thoughts are.
So what I say is and the reason why I ask your specific specialties you're interested in is try to find something that will overlap between the two for building your CV wise. So that way you're not rerouting your whole CV. Like if you're going from, let's say like OBGYN to neurology, like those are two totally completely different specialties. So first off, let's talk about building your CV and getting you competitive for either one. So EM and Gen Surg, you can talk about anything critical care. Boom. Good, you're done. That could be anything from airway management to CVL infections to anything, like anything, you name it, chest tubes, hemothorax management. That's all going to be good for EM and Gen Surg. All right, so that covers that. Find overlapping within the specialties to build your CV. Next, talking about with rotations. This is where it does get tricky. You can do half and half. So let's say, how many months do you have for elective rotations?
You mean total?
Yeah, like how many are you able to get in, let's say, before December?
Oh, I think at my school you can kind of start whenever you want. Actually, I need to double check the schedule, so a little unsure on that.
So let's say, and the reason I ask is because everybody's clinical year is a little bit different. Let's say that you start in July. So let's say July, August, September, October, November, December. So that's like 6 months. So what I would do, first off, I would see, do I have enough letters of rec? Most people don't get enough letters of rec in their third year of med school to be able to apply for anything just because you don't do enough rotations in that specialty. Maybe you get one or two, right? And the good thing is one or two letters of rec can carry over between Gen Surg and EM, but you can't have 3 EM letters and then apply for Gen Surg because that's just not going to work. They're going to be like, well, do you really want to do Gen Surg? Why are all your letters in a different specialty? But if you have 1 EM letter and 1 Gen Surg letter, then for example, that's fine because then you can just backfill the rest of your letters with the other specialty of whatever you're going to end up applying for. So that's the first thing with the letter of rec. What I would do in terms of rotations though, is I would do like, for example, July Gen Surg, August EM, June, July, August, September Gen Surg, and then next month do EM. And then so alternate until you're actually sure, because number one, you're going to be able to continue getting experience. And number two, you are not completely pigeonholing yourself, because if you like front load all your EM rotations and then you're like by your second month you're like, dude, I don't like this, I want to do Gen Surg, it's like going to be too late because you don't have your letters of rec in. But you have to keep in mind that ERAS usually opens around September. So if you have July, August, September, that's only 3 months. So that's really, really tough. You need to make sure you have a minimum of 3 letters of rec to apply. And you can always submit a fourth one later, which is fine. But long story short, it gets very complicated if you're split between 2 specialties. I'll type out some guidelines here for you in just a second. But the short answer is the sooner you know, the better. And so I would recommend to create a pro and con list out everything, sleep on it, discuss it with family, send it over to me. I'm happy to look through it and we can see why you want to do one specialty versus the other. Because oftentimes as a med student, you don't really know what the specialty completely consists of. And so sometimes what you like about one is actually more relevant to even the other specialty. So I'm happy to discuss that.
Gotcha. Thank you. And then my other question's a little quicker, but I was given the advice that as a third year, you could start reaching out to program directors of programs you're interested in, like ask to sit down with them, get advice, etc. Do you recommend that, or is that like a little too eager?
Nothing wrong with that. It's just an extra touch point. It's not going to make or break anything, but certainly if you have a home institution that you can chat with the program director or somebody on the faculty, then by all means I would do it. They can sometimes even just remember your name in the future and be like, oh, that guy was pretty cool. Let me see what he's up to and maybe give him an interview when your application comes in.
So you don't think like it would be annoying them, especially when they're like it's an application season right now?
I mean, you don't have to do it right this second, but you can also just email them and ask them what would be a good time. Would it be better to reach back later? Like, what's their availability? I mean, it's not like you're emailing them and they're like, yeah, I'm going to get you in tomorrow. Like, it's not going to be like that at all. Be like, hey, like, when would be a good time? I had a couple questions about the specialty. I would love to sit down and meet with you for 15 minutes. Is that possible at any point in time? Boom.
Gotcha. Okay, thank you.
Yep. Awesome. Anybody else have any questions? These are great. What else you guys got for me? Go ahead and just shout it out. I'm going to continue typing while I wait.
Hey, Dr. Price, can you hear me?
Yeah. What's up?
Okay, so I have two questions. One is, well, I'm studying for STEP and I want to see how best I can like ramp up my questions from right now I'm doing like 60 and I want to get to the point that I can do like maybe 120 per day.
Okay.
And the second question was kind of similar to what Rohan was saying, because I've always been interested in gen search, but recently with the case report I did with neuroradiology and then presented it, I kind of like was thinking more of like what the specialty has to offer, but the kind of lifestyle that I see for myself,
Okay.
which is a different way in which you tell us, to like look at specialties, see one versus the other.
Mm-hmm.
So I don't know what thoughts you had on that.
Okay, so first question is increasing number of UWorld questions, and then second question is determining specialty. And more specifically, you wanted to discuss lifestyle versus what the specialty is. Is that correct?
Yeah.
Okay, so let's talk about increasing your UWorld questions first. Can you walk me through day by day right now? Like, what'd you do today?
Okay. So first thing today, I woke up a little later than I hoped because yesterday I stayed up doing Anki. So I finished some Anki, then I did a block of questions and breakfast, some rest and stuff, and then I went on to review my questions with first aid, seeing the QID for Anki, and going over the videos. That took me some time because I hadn't finished those pathoma chapters. When I hated that question. I thought lipoma, but it was actually a ganglion cyst. And almost everyone thought lipoma just like me. And I was like, what? But yeah, going over the Ankis. When I went over the Ankis, I also looked at extra cards with regards to videos. And then instead of hitting my 60, I did 15 more. Because I was like, I feel a little bit tired because I hit videos of things that I wasn't strong on.
Okay, so I'm writing out some recommendations here based upon what you told me. Let me put my cat outside. She's like meowing like crazy.
Okay.
Can you see my screen?
Yeah.
Okay, perfect. So one of my rules of thumb is you always want to start your morning with what the most difficult task is going to be for the day. So before looking at Anki or Pathoma or anything like that, I recommend to just bang out your questions first things first, because you're not asking me how do I get more Pathoma videos in. You're asking me how do I get more UWorld in. Well, you got to make more time for UWorld. Do it when you're fresh in the morning, because when you're fresh, you're going to, number one, have more motivation and discipline. These are finite resources. You get more tired as the day goes on. As your fatigue goes up, your speed goes down, your motivation goes down, your discipline goes down. So if you want to do 120 UWorld questions, then just try tomorrow to do 120 by 3 p.m., 4 p.m. And then whatever you get done in the evening is what you get done. You're going to be more tired. You're not going to be able to do as much Anki and Pathoma. Who cares? That's not your priority. So prioritize, front load your day with what you need to get done. And literally before you start changing a ton of different things, I would try that first.
Okay, so would you suggest I do a block, review that block, do a next block, review that block, or do the 3 blocks and then review all of them?
No, I would personally rather you alternate it.
Okay, yeah.
And this advice changes from time to time based upon where you're at in the process. But just from where you're at right now, what I would do is to alternate. So do review, do review, do review.
Mm-hmm.
The only time that, and I say only, but in general, the only time where I would say for a student to do 2 or 3 blocks back to back is when they're gearing up very close to their test and they want to build their endurance rather than their knowledge base. And right now you're at the knowledge base building phase. And so you're going to be able to get more out of it by reviewing it immediately after than you will about building up your endurance, your speed, that kind of thing. Because right now, if you review a question like pretty soon after you do it, you're not going to have to sit there and reread the whole prompt because you're like, oh, okay, I remember this question. Yeah, let me just roll through this. Boom, you got it. Whereas if you did 120 questions, by the time that you like get a break, go back, now start reviewing. By the time you start reviewing and you get clear to the end of your reviewing, which is going to be like 7 hours later, you're literally not even going to remember what that question was about. And so right now, I'd rather you alternate.
Okay, great.
Good questions. So try that out. Let us know at the next live if that works. If not, I mean, there's plenty of other things we can do. Another thing is to do your videos with your meals for the day. So breakfast, lunch, and dinner. If you're intermittent fasting, then lunch and dinner, for example, you can watch your Pathoma during that. It's better to do that while you're multitasking, even if you're in the shower. If you're driving, you can listen to the audio for it. Stuff like videos is best done while you're doing something else. Even if you're like doing your dishes or folding your laundry, like banging out multitasking that way. Obviously, you can't do questions while you're folding your laundry, but you can certainly do a video. So I'm okay with multitasking whenever it comes to the video content like that. So those are really the biggest 2 or 3 things that I would change right off the bat. Another thing that you can do is to invoke Parkinson's law. And so set a timer to constrict the number of hours it takes you to do your questions. So I want you to do an experiment for the next 2 days. So tomorrow, I want you to do 40 question, review 40 question, and then do 40 question, review 40 question, etc. As many blocks as you're going to do. So you want to do 120, so do review, do review, do review. Time yourself at don't look at the timer, don't mess around with it. Just like literally see what time you start and then see what time you finish. Okay? See when you start and when you finish. Write that down. And then next day, what I want you to do is to take the total time from previous days studying. So let's say that to do and review 120 questions, let's say that took you, 10 hours, 12 hours. Let's say 10. We'll make it easy on ourselves here. So that took you 10 hours. What I want you to do for the next day is to actually only give yourself 8 hours to do it. And so it's going to be very difficult, but to compress your timeline down, you're going to have to be doing and reviewing like 15 questions per hour to get through all of them. So I want you to take the total time from previous days studying and compress the hours by 20% and aim to complete your questions in that constricted time frame on an hourly basis. Does that make sense? So if day 1 took you 10 hours to do 120 questions, multiply 10 hours by 20%, we'll say by 0.8, so that's going to be 8 hours. Take your 8 hours and evenly distribute the questions. And so if you take 8 times 15, you get 120 questions. So that means you have to do and review 15 per hour. Does that make sense?
Yeah. So I leave the timer for the total amount of time.
For the first day. Yep.
Okay.
Like you're not compressing the time. You're literally just seeing how long it takes you.
Mm-hmm. Okay.
And then the next day you actually set hourly alarms and you have to be through 15 questions in that hourly alarm. Do you follow me?
Yeah. You just told me this and I thought in my head like the perfect place because I noticed that when I go to a cafe near my house, I'm a lot faster. When I go to the library at school, in the morning I'm faster. But if I stay in my home desk, I'm a little more lenient.
There you go. You have solved your problem without me. You already know the answer.
Yeah, it happens.
So if you do this, you go to the cafe, go to the library, and use this Parkinson's law to compress your time, almost guaranteed you will get the most productive next few days that you have had in all of your studying.
Okay. I'll try my best and get back to you on that one.
Awesome. Phenomenal questions, guys.
Do you keep compressing the following day or just stick to that 8 hours?
Once you can comfortably do the 8 hours, then you can start compressing, but you're not going to be able to just compress by 40% right off of the bat.
Right.
I would make sure that you can do the 8 hours without having the hourly timer. So like, let's say you hit the 8 hours 3 days in a row doing it this way. let's say on day 4, just see if you can keep that pace without the hourly timer. Most people will actually slow down tremendously because they're so used to being revved up, trying to aim to hit that hourly limit. And you're like 40 minutes in and you're like still in question 5. You're going to like keep pushing harder and harder to make sure you get it all done. But when people don't have that timer, they generally will balloon their time out to maybe even like 11 hours. So you have to like really keep an eye on it and don't try and ramp it up too quickly. So once you're used to the 8 hours and you can pretty calmly get through that, then that's the time to compress it again.
All right.
And then, for the other question, determining your specialty lifestyle versus what the specialty entails. I would recommend to make a pro-con list before you do anything else, because you've only told me 2 data points right here, lifestyle and then the actual procedures and whatnot of the specialty. So make a pro-con list for each specialty and then sleep on it, discuss with family, send it to me with any questions. That's what I would do.
Okay.
Because lifestyle is definitely certainly a big part of it, but by no means is it the reason to pick a specialty. Because at the end of the day, you can make the lifestyle whatever you want to make it. Like if you want to have a more chill practice, then you tailor your marketing, your patients that you take, your clinic, you tailor everything towards that specific pathology that's more quote unquote chill. Like for example, for vascular, if you only did vein work, that would be a lot more chill than dealing with aortic dissections and like aortic ruptures and stuff like that. And so they're not going to send you those patients if that's not what you deal with. You kind of like create your own niche. So you can do whatever you want within pretty much any specialty, but obviously within certain constraints. That's something to keep in mind too.
Yeah, that's a great point, actually.
I have one last question.
Yeah, fire away.
So, I'm starting to prep for step 2. I'm following the flow chart that you sent me of internal medicine. But since I'm not on rotation and I have like more free time, I don't know how many videos I should be watching per day to like make the most of them, or if I should start questions right away. I don't know if I should make any change.
So I wouldn't start questions right away if you haven't went through the baseline videos in the algorithm. But the answer of how many I should be watching is however many you can fit into a day. Obviously, there are going to be different lengths. Like not every video is an hour long. Some are 20 minutes, some are 2 hours. So see how many hours that you're willing to study per day. Let's say 10 hours, and see how many videos that you can chunk into that 10 hours at 1.25 or 1.5 speed or whatever you're listening to it, and just make it your goal to get it done in that amount of time. It might end up taking you 11 or 12 hours with your breaks. That's fine. But I always say overshoot a little bit on how much you want to accomplish and then undershoot how many hours you plan to actually work, because you're going to do a little bit more. And that's just human nature as a high-performing med student. So I would just look at it like that.
Okay, great. Thank you.
Absolutely. Anybody else have any questions?
I'm not sure if you made a crash course for OBG yet, but I was wondering if you had any tips for like questions about abnormal bleeding or stuff like that.
All right, here we go.
Oh, nice.
Let's see. We got not just a little bit. We have 24 pages here.
Dang.
All right, I'll type in abnormal uterine bleeding and we'll just go through some of the stuff here. So if it's abnormal uterine bleeding, the patient is older than 45, you want to get an endometrial biopsy. Higher risk that they have a cancer at that age range. And so if the biopsy doesn't show anything, then you can do a DNC at that point. We're just going to fire through these here. I'll send you this guide. It's not completely 100% published yet, but it's got a lot of really good stuff for you. Let's see. Let's start at the top. Oh, this is actually what I was looking for. So here's the abnormal uterine bleeding scenarios. So if you have bleeding plus a positive beta HCG with an intrauterine pregnancy and a closed cervical os, that's a threatened abortion. You got to make sure that you know that. These are some of these are going to be emergency situations, and some of these are very chronic. So for example, F down here is bleeding plus weight gain, constipation, and fatigue. That's usually going to be hypothyroid or PCOS. So you have to use the whole clinical scenario. If they say the patient is pregnant and they're bleeding, obviously that's something that's a lot more concerning than somebody that's slowly gaining weight and constipated and bleeding. The bleeding plus bitemporal hemianopsia, you guys have heard that before. That's prolactinoma. So you want to get an MRI of the brain, see what's going on. And then treatment is dopamine agonist like cabergoline or something like that. Abnormal bleeding starting with menarche. So usually it's because of anovulatory cycles. It's literally they're just developing. They haven't got their menstrual cycle down to an exact 28-day science yet, and it's from an immature hypothalamic pituitary axis. But if it's heavy bleeding, or they make it sound like the patient is bleeding for a lot longer than you'd expect, let's say that they're like, every month the patient bleeds for 2 weeks, for example, and it seems like it's getting worse and worse over time, then that may be a coagulopathy, such as von Willebrand disease or factor V Leiden. If there's bleeding in menopause, you want to assume cancer in a question stem until proven otherwise. So you can get an endometrial biopsy, like I just was saying a little bit ago, especially if they're over 45, they're going to be getting closer to menopause. So you want to fire away with an endometrial biopsy. If they have bleeding plus severe menstrual pain, the pain here is really, really key. You want to start thinking endometriosis or adenomyosis. If they mention that it's like a boggy, uniform shaped uterus, then you're going to go with adenomyosis. But if it's like a nodular uterus that you feel in your exam or that you see on imaging, then you're thinking endometriosis. If there's bleeding plus weight gain, constipation, fatigue, we said it was hypothyroid or PCOS. If it's a positive beta HCG with your bleeding, pelvic pain, but there's no fetus in the uterus, or they might say that there's an adnexal mass, that's going to show you that it's an ectopic pregnancy. You have to know this. You almost guarantee get a question on it. And so as you see here, ectopic will be a pelvic ultrasound showing an adnexal mass. And they can also give you a clue that there's a thin endometrial stripe. And that just basically means that the uterus doesn't have any proliferation or any growth. And so for the ectopic pregnancy, the treatment is going to be methotrexate. But if there's a contraindication to methotrexate, such as liver, kidney, immunodeficiency, peptic ulcer disease, pulmonary dysfunction, or an ectopic rupture, then you do a laparoscopic salpingectomy instead. That is more of a step 3 question. They're not going to push you much past methotrexate on step 2. Yes, it's possible they can ask you it, but they'll try and make it very obvious. They'll say something like there's free fluid in the posterior cul-de-sac, so you pretty much assume that it's a ruptured ectopic at that point. If the patient has fetal cardiac activity or super high beta HCG, like 1/5,000, then most of the time it's just better to go straight to salpingectomy. Methotrexate is not really as effective in these circumstances. So if you see ectopic pregnancy, generally you're going to go with methotrexate. The patient's got trouble with their kidney, liver, lungs, GI, peptic ulcer disease, immunodeficient, you're going to go with a laparoscopic salpingectomy. Obviously, you can have a bump in your LFTs with methotrexate. Your creatinine can take a hit. If they're immunodeficient, you don't want to just give them more of an immunosuppression medication like methotrexate. Puts you at high risk for peptic ulcers, all kinds of stuff. So if any of those are the case, you do laparoscopic salpingectomy. But the real key here is if it's ruptured, then you're definitely going to want to go to surgery instead. And this is kind of a step 2 or a shelf type question. If the patient is hemodynamically unstable and you suspect a ectopic pregnancy based upon the adnexal mass with a positive beta HCG, then you're going to just skip the imaging and go straight for the emergency laparoscopy, right? Pretty much any time in a question stem, they give you very low blood pressure with a very high heart rate, you're going to want to go to surgery rather than kind of muck around with imaging. And then last one here is most common cause of regular heavy menstrual bleeding in a non-pregnant premenopausal woman is going to be a uterine fibroid. And they'll list that oftentimes as endometrial leiomyoma in the question stem. It's just another word for it. Does that answer your question about bleeding?
Oh, yeah, definitely.
Awesome.
Thanks for sharing that.
Yeah.
But I just wanted to quickly ask, because I saw prolactinoma. I
Yes.
always get that confused with pituitary adenoma. Which one is surgical removal?
Pituitary adenoma versus what?
Prolactinoma
Well, what is a prolactinoma? Where is it at?
in the hypothalamus?
No, it's the same thing. It is a pituitary adenoma.
Oh, right. Okay, yeah. Sorry.
No, you're good. So, good question.
Thanks.
All right. Anybody else have any questions? We're closing up here on exactly an hour. So if nobody has any other questions, then we'll just call it a day.
Thank you
Awesome.
so much.
Yeah, absolutely. Thank you guys for coming. Hopefully that was helpful. As always, let me know if you have any questions. We're going to do another session, I think, same time next week. Check the calendar just to be sure. Double check me on that one. But great to see you guys. Thank you all for coming. Thank you for the good questions. And if you need anything, just let me know.
Thanks.